Thank you very much for that. So now, as you may have heard, the Minister was unwell and unable to be with us, but we're delighted that Catherine Calderwood, the Chief Medical Officer, it would be very bold of me coming up from London to introduce the Chief Medical Officer to you, so I'm not going to do that. But instead, stay. We're delighted that you could join us.
Well, thank you very much. I perhaps wouldn't applaud until you've actually heard me read a speech that was handed to me at 1:45 and prepared for somebody else to give. I'm delighted to be here, and I hear that this conference not only has been fully subscribed, but had a waiting list, which is really a very important message, I think, that people in Scotland find all of these areas extremely important, and that we've gathered together people from many, many aspects of healthcare, social care, education, the third sector, and others who are willing to work together in this area. And perhaps in Scotland we have a population a size of which means that we perhaps can get more traction and better spread of what we find important. I'm an obstetrician and I still have an antenatal clinic when I can get there, but I thought perhaps I would start this with a story. I've changed the names of these people. It's very, probably very telling when you yourself are going through the same experience as some of your patients. And what I always found very difficult was when I was looking after pregnant women, when I myself was pregnant, and their circumstances were very different to mine. So I first met Pauline because she had had a stillbirth of her 6th baby. Pauline was 21 at that time. And she was with a man called Ian. And Ian and Pauline had these children between them, and then we got to know them a little bit better in maternity services because of the stillbirth. She had various risk factors for stillbirth: smoking, drug use, and she was from a socially deprived background. So we got through that episode, and I next met Pauline again 3 years later, pregnant with her 9th child. She was 24, and I asked where Ian was. "Ian's not here, doctor," she said. We'd had a nice to see you again. "Ian's not here, doctor." "Oh, where's Ian?" "He's in the jail." GBH, 5 years. And I wondered about those children that Pauline and Ian had shared a home with since I had last seen her. "But this is my new partner, Jamie," she said. "Hello, Jamie." Jamie, it became clear, wasn't the father of the 9th baby. That was Ian. And Jamie had 4 children of his own. But they told me that Pauline and Jamie wanted to have another child together once this one was born. Several of her children were with her in the consultation. It was quite difficult because we were trying to do a scan. The 2-year-old was crying. The 3-year-old was lying across her tummy. Makes it practically quite difficult to see the baby. And I said to Jamie, "Maybe you would take one of the children out to the waiting room. There are some toys." "Nah," he said, "they like it in here. They like watching the telly," meaning the ultrasound black and white scan. I then said, when the 2-year-old wouldn't stop crying, "Jamie, have you got anything is the baby maybe hungry?" Pauline said, "Oh, here we are, Jamie." She reached into her handbag and produced one of those plastic cups with the non-spill lid, the type of plastic cup that I had sent my child to nursery with that morning. And I thought, brilliant. She's got a cup of milk for the baby. "Go on out to the vending machine, Jamie," she says, "and get a can of Coke and put it in there." Jamie came back in, unscrewed the lid of the plastic beaker, poured the Coke in, and Pauline said, "There's a poke of sugar in my bag." Tesco bag in the corner. Tipped the sugar in, the baby will drink it. So I was about the same number of weeks pregnant with my third child at the same time. And I wondered how those children were going to be when Pauline and Jamie had them at home. And I've told that story several times to non-clinical audiences, and what they said was, why didn't you do something? Why didn't you do something about that? And the obstetrician, that was me, said to my friends, but what could I have done? Short of bringing the baby home with me, what could I have done? We were just talking earlier, because Sir Michael Marmotton, a group of us have just been discussing what are the barriers to changing adverse childhood events. And some of the barriers are exactly illustrated by my story. Because really, what could I have done as the obstetrician that had 20 minutes to scan that baby? I saw all of that going on around me. But what could I have done, really? And is that perhaps part of our issue? Is that some parts of our system don't understand each other, don't necessarily speak to each other? And I would certainly tell you, I didn't know how I would have helped her find benefits or get better nutrition for the children. Because I was an obstetrician performing an ultrasound scan, and that was my job. That was my bit of the system. So how many other bits of that couple's system didn't understand each other and didn't join up to help that couple? So perhaps I leave that with this room as both a challenge and an inspiration that there is more we could be doing. But I have a speech to give. So we have in Scotland many different initiatives to try to bring together the importance that we see in having our children have as few adverse experiences during their childhood as possible. We have the Getting It Right for Every Child policy that I know everyone in this room will be familiar with. And we also have our Early Years Collaborative, which is unique in the world in bringing together people from different parts of the sectors that look after children, and people who then are joined up together to admit that, exactly as my story illustrated, it can't be just one part of the system that looks after our children as they grow up. So we've had many challenges. We have, though, I think, made good progress. I think many of us have heard some of the results from that Early Years Collaborative, particularly in the reduction of stillbirth and neonatal death, particularly in bringing in our 27 to 36-month check. And we're going to measure how we can really go forward with that to make sure that we are achieving what we're setting out to achieve from some of these policies. So again, as I said, Scotland, a small country, perhaps we can get more traction and more movement towards positive outcomes. So our GERFEC policy puts children and their families at the heart of decision making. And it is really aiming to realise the Scottish Government's goal of giving children and young people the best start in life. It puts the rights and well-being of children and young people at the heart of the services that support them. Early years services, our schools, the NHS, and encourages those children to be part of their care, to listen to what it is that children and families need. Each child is, of course, unique. There's no set level of well-being. What's important to some families has a different set of experiences and different sets of importance and value in other families. But we have many parts of the system, health visitors, teachers, GPs, the police, who need to work together to promote and safeguard the well-being of all of our children and to help them realise their full potential. We hear about children in schools where that potential has taken on a nihilistic type of attitude. Well, they're from that community. They're from that part of deprived Scotland. Perhaps it's just getting them through their education, not actually aiming to say, what is this child's potential? Can we actually, in fact, raise what they might attain, rather than just leaving them at a level where they started? I've had quite a lot to do with trying to prevent maternal deaths in Scotland. And I use this story to illustrate that cycle of expectation, I suppose. So we were looking into a death of a woman who had committed suicide at the age of 21. She'd committed suicide about 8 months after her baby was born. And she had problems with drugs and alcohol. But you get to read the whole of the background of people when we're doing an investigation. And what really struck me about that girl was that her own mum had died when she was 16 of alcoholic liver disease. And she had been then through the system with some foster care and some residential care, went on herself then to develop drug and alcohol problems, and ultimately her child was left without a mother a generation later. But might we have perhaps shrugged our shoulders and said, well, what would you expect? What would you expect if that's the background that that child came from? What had she learned when she was at home? And that's what all of you in this room are aiming to get away from, to change that cycle and that fatalism and that there's nothing we could do. And I think that we can achieve change, and we can achieve taking that situation and doing something different for that baby, because that's going to be the next part of that cycle, was taking that tiny baby less than a year old with that background and making sure that history didn't repeat itself yet again. So I mustn't forget the investment that we've recently announced in postnatal depression, in mental health and well-being for pregnant women and for children and young people. Postnatal depression is the commonest complication of pregnancy, affecting 12% of pregnant women. Commoner than all the things that we do all the checks for in the antenatal clinic, like diabetes and blood pressure problems. And of course, mothers with postnatal depression have a profound effect on the way they bond with their babies. And we know that children whose mothers have had postnatal depression are less resilient at the age of 9 and much more likely to go on to develop mental health problems themselves if that mother hasn't been diagnosed and treated. So early intervention is what's needed in some of these. This is medical examples or clinical examples, but also the importance of that early intervention when we see circumstances in which children are being brought up and where they are likely then to go on to develop longer-term problems such as you've heard about today. In some areas of Scotland, 6% of children have holiday hunger. That's where, when the school holidays do mean that they are not provided with a school meal, they go hungry that day. That's a shocking statistic in our society today. I wanted also to talk to you, though, about another of our really good interventions in the form of link workers. Many of you will already know that what we have done in Scotland is have 40 link workers as part of a pilot project who go into GP practices in our most deprived communities and link the people who are coming into those practices with different services that are outside medicine and the hospital environment and the clinic environment. So a guy who was in my year, in fact, at medical school, called Peter Coston, works in Drumchapel in one of these deep end practices, and he came to tell me to see me. He brought along Maureen, his links worker, with him. She told me the story of the woman that had been to see Peter as her GP. A young woman, 2 children on her own. She came to see Peter and said to him that she was suicidal, that she felt that she couldn't go on, and she wanted him to help her with some kind of treatment. And Peter thought, call this crisis services for mental health provision. This is a young woman with 2 dependent children who really is significantly, saying to me very significant symptoms of mental health problems. But he decided to probe with her a little bit more about why she was feeling so bad. So during a house move, something in the administrative system had meant that she did not have her benefits renewed to her new address. So she had had a fortnight where she had had no money at all coming into the house. Her children were literally starving. If she couldn't get them to go to a friend's and manipulate the timing of that visit to incorporate a meal time, then the children had no way of having any food. Perhaps not surprising that she felt that she couldn't go on. She couldn't see a way out from that. The links worker in the practice took her aside. Peter didn't press the mental health services crisis button. £200 emergency loan, took her to a food bank, provisions for that next few days for herself and the children, and the next day into the office to sort out the problem with her benefits to make sure that those were reinstated. No medicine at all, but actually that was exactly what that young woman needed. And that links worker completely transformed the care that that woman got. Imagine if she'd been admitted to a psychiatric hospital as a suicide threat, or treated with medication, leaving her 2 children who would have inevitably gone into some form of care because they would have needed to be looked after. So what happened was she had a medical cry for help for not a problem that was medical at all. But the links worker system recognized that problem. And what Peter said to me was, if we hadn't had that links worker, would have had no choice but to go down the mental health crisis pathway. So you'll be pleased to hear that we have committed to rolling out another 250 links workers to our most deprived GP practices across Scotland in the next few years. Some of this is about realistic, not medicine. We talked a little at the beginning of closing the attainment gap, and we want Scotland to be the best place in the world to grow up. We want to achieve equality, equity in educational outcomes, focusing very much on the poverty-related attainment gap. And we want to have focused, accelerated and targeted improvements in our literacy, numeracy and health and well-being. We know that these are challenging times ahead, but I'm delighted that Scottish Government is absolutely committed to the Raising Attainment agenda. Some of you may know that the First Minister recently announced a review of our care systems as we realise that looked after children, very important part of their lives. This is a complex area, and this review will be a complex undertaking. But we need, we think, to look at how we're looking after our children in Scotland and to review that again in order to make sure that we're having the best care for those children and that they are attaining the best of their potential. As you're all well aware in this room, there's a much higher risk of adverse childhood events if you live in a more deprived community. Inequity in outcome, inequality of power and wealth are at the root of inequalities in health. And if we're to tackle these inequalities, we need to tackle the determinants of health, which of course Sir Michael Marmot put so eloquently in his report, Fair Society, Healthy Lives. The Fairer Scotland Action Plan was published recently, and this will be central to achieving our ambitions for Scotland's children. The key pillars around ending child poverty, a strong start for all young people, fairer working lives, and a thriving on beyond their childhood. And this will help create the conditions to support child and adolescent health and well-being. So in conclusion, I hope that you realise from the various policies that I have outlined that Scotland really is committed to reducing adverse childhood events, committed to raising attainment in our children and young people, and making sure that Scotland really is the best place in the world to grow up. So thank you for coming, all of you. Real leadership, I think, in this area is shown by the commitment of all of you in the room, the fact that the conference is not only full but oversubscribed, but it's up to you now to help us achieve these ambitions. Thank you.